Well, good morning or good afternoon. My name is Joy Burkhardt, and I'm the Executive Director of the Policy Center for Maternal Mental Health. We are a nonprofit think tank and convener whose mission is to close gaps in maternal mental health care. Welcome to members of Congress, congressional staff members, media, and others interested in this important issue. Our briefing today is titled Bipartisan Congressional Briefing, the latest insights and opportunities for improving family planning options and maternal well-being. I invite you to learn more about our work on our website and to download the Policy Center's Congressional Briefing brief titled The Link, Family Planning and Maternal Mental Health, which is being dropped into chat right now. Today, we'll be discussing the latest in family planning developments and the impact of unplanned pregnancy on maternal health and well-being. We will outline federal family planning policy, the status of access to contraception in the states, the economic and tax impacts of unplanned pregnancy, innovative contraception for men, as well as federal and state policy recommendations that we know both parties are thinking about. We wish to thank our sponsor, Organon, for supporting this briefing. Organon is a global healthcare company with a focus on improving health of women throughout their lives. Organon is committed to delivering innovation, improving access, and expanding choice in reproductive health care. Organon is proud to work alongside organizations informing, educating, and supporting policy that will ensure all women can plan for their future. Now, before we begin, I imagine that all of you attending today are aware that the U.S. is experiencing a crisis in preventable maternal deaths, with the latest research out just last week showing that maternal deaths are continuing to rise. Of course, with an increase in births in the U.S., these horrific statistics will continue to go up. It's also important to note that while no woman is immune from the maternal mortality and morbidity crisis in America, Black and Indigenous women are experiencing rates 4 to 5 times higher as white women. These populations also experience maternal mental health disorders at higher rates. I want to now take a closer look at maternal mental health. Maternal mental health disorders are the most common complications of pregnancy and birth, and also a leading cause of maternal death. Maternal mental health disorders impact up to 1 in 5 women on average. And as I mentioned earlier, women of color experience rates at much higher rates than white counterparts. Maternal mental health disorders encompass a range of disorders, including but not limited to depression, anxiety, obsessive compulsive disorder, birth trauma, and psychosis. These disorders can occur during pregnancy as well as the postpartum period, and are often referred to this period as the perinatal period. These illnesses are caused by a combination of biological and psychosocial factors, including social stressors, such as previous personal family history of these disorders or lack of practical and emotional support. Maternal mental health disorders can be devastating to mothers, fathers, infants, children, and society. In fact, due to the factors such as long-standing developmental impacts on children and a parent's ability to work, research conducted by Mathematica found that the cost of untreated maternal mental health disorders totaled $14 billion, with an average cost of $31,000 per mother-child pair, with postpartum illness specifically. And that's an annual cost to the U.S. The good news is that we can reduce the likelihood of these disorders by supporting women and men in planning their pregnancies and preventing unplanned pregnancies. Again, welcome and thank you for being with us. And now I have the great pleasure to introduce our moderator for today's briefing, Brittany Fredrickson. Brittany is an Associate Director for Women's Health Policy at KFF, formerly the Kaiser Family Foundation, and is also an epidemiologist. She focuses on contraceptive access, including Title X policy issues, and is involved in many of the surveys and data analyses conducted by KFF's Women's Health Policy team. Prior to joining KFF, she was a health scientist at the Office of Population Affairs at the U.S. Department of Health and Human Services, where she focused on developing and maintaining the National Quality Forum endorsed contraceptive healthcare quality measures. Brittany, it's a pleasure to have you joining us. I now turn it over to you, Dr. Fredrickson. Thank you.
Thank you so much, Joy. I think we're having an issue with the video. I'm not able to turn on my video, Sarah.
Brittany, while we're working on that, we'll go ahead and have you
I'll get started.
Start your presentation. Thank you.
Okay, excellent. Thanks for the introduction, Joy. As Joy mentioned, I'm Brittany Fredrickson. I'm an Associate Director for Women's Health Policy at KFF, and I'm pleased to be moderating today's congressional briefing. At KFF, we are a nonpartisan nonprofit organization that serves as an independent source for health policy research, polling, and journalism. And we focus on U.S. health policy, particularly healthcare coverage and access to care. Over the past several years, like Joy has said, we have seen a growing interest among policymakers on two major health policy areas, maternal health and mental health. So I'm really excited about the Policy Center for Maternal Mental Health that has brought us together to talk about this issue. I'll just start briefly by setting some context today. And I'll start with health insurance coverage for women, which is really the floor. And most reproductive age women have private employer-sponsored insurance, while 1 in 5 have Medicaid coverage and 12% remain uninsured. Next slide, please. The Affordable Care Act requires private plans to cover prescribed contraceptive services and supplies for women without cost sharing. And this does not include vasectomies or over-the-counter methods, including condoms and spermicides, featured on this slide. One of each of the FDA-approved, granted, or cleared methods must be covered, and a plan must cover a method or brand that a provider recommends. On the slide are the FDA-approved, granted, or cleared methods. However, there have been ongoing reports about problems with plan compliance, especially regarding some newer methods like Phexxi, the vaginal gel, Annovera, the one-year vaginal ring, and Twerla, which is another contraceptive patch. Next slide, please. The ACA contraceptive coverage requirement has been highly successful, with 70% of privately insured women saying their insurance coverage covered the full cost of their last contraceptive method. However, even with the ACA coverage requirements, 16% of women with private insurance say they still had to pay part of the cost of their most recent contraceptive method. And a quarter of those paying out of pocket say they paid $50 or more out of pocket for their last method. There are a number of reasons that someone may have to pay part of the cost of their contraception, even though they have private coverage. Some people paying out of pocket could be receiving care out of network, or they could still be enrolled in a grandfathered health insurance plan, which is exempt from the requirement. They could also be enrolled in a plan with religious exemptions. Trump administration regulations that are still in effect allow exemptions for employers who have religious or moral objections to contraception. The Biden administration has issued proposed rules for contraceptive coverage that eliminate the moral exemptions and creates a new mechanism for no-cost coverage for people insured by employers with religious objections. But the final regulations have not been issued yet. With affordability being one of the main reasons women are not using their preferred methods of contraception, there is more work to do to ensure that they can get their preferred methods without cost sharing. Next slide, please. A number of states have passed additional contraceptive coverage policies to ensure access to contraception. 29 states in DC, in orange, have passed laws that build on the federal requirement for no cost sharing for FDA-approved contraceptive methods for women. And some of these states have gone beyond the ACA requirements, mandating coverage for over-the-counter contraceptives, which are the lighter orange, or coverage for vasectomies, not featured on this slide. Next slide, please. Medicaid is the largest public payer for family planning in the US. Family planning is a mandatory benefit under Medicaid that all states must cover. Cost sharing is prohibited, and the federal government pays 90%, which is unique compared to other services. Managed care enrollees may go out of network to get their family planning, and beneficiaries may get care from any willing participating provider. There's no federal definition about what states must include as a family planning benefit. And while all states do cover prescription methods, some states have other policies that limit utilization, such as preferred drug lists or requiring a prescription for over-the-counter methods. There are currently 30 states that extend Medicaid coverage for family planning only to individuals who do not qualify for full scope Medicaid coverage. And that's through a state plan amendment or an 1115 waiver. Next slide, please. And I'll talk briefly about the federal Title X program. That's the safety net for individuals without insurance or those with lower incomes who need reduced or no cost family planning services. The network has undergone a number of changes over the last several years. And under the Trump administration, a number of clinics left the network because they were no longer able to refer for abortion services or have co-located abortion services. This resulted in over 1,000 clinics leaving the network. However, many of the clinics have rejoined under the new Biden regulations that once again allow people to refer for abortion services and have co-located abortion services. There are currently 2 states, Tennessee and Oklahoma, that have recently lost their Title X funding because of state policies that do not allow pregnancy options counseling for abortion services in their states because of the abortion bans currently in their state. Next slide. And while a large majority of women receive their contraceptive care in private doctor's offices, clinics like Planned Parenthood clinics, Title X clinics, and federally qualified health centers play an important role, especially for Black and Hispanic women, with nearly 1 in 5 saying that they got their most recent contraceptive care at a clinic. Next slide. And I'll end these brief set of slides with the Biden administration's recent executive order on strengthening access to affordable, high-quality contraception and family planning services. The administration suggests considering guidance for private plans to reduce some of the barriers that women are facing in accessing contraception prescribed by their provider, increasing access to over-the-counter contraception, including emergency contraception, expanding access to family planning services and supplies across Medicaid programs, such as sharing best practices for state Medicaid programs, strengthening the coverage of contraception through Medicare Advantage and Medicare Part D plans, ensuring robust coverage of contraception for service members, veterans, and federal employees, encouraging federally supported healthcare and human services entities, such as the Title X program, community health centers, and the Indian Health Service, to expand the available and quality of contraception access for those they serve, identifying and sharing best practices for employees and insurers and making affordable, high-quality contraception available to employees, and bolstering access for college and university students. And finally, supporting research, data collection, and data analysis on contraception access and family planning services, some of which we will hear about today. Throughout today's briefing, we invite you to ask your questions in the Q&A feature of Zoom. We have allotted time to answer your questions after the presentations. And now I'd like to introduce our speakers in order of their presentations. Their full bios can be found on the Policy Center's website. First, we have Dr. Kelly Stidham Hall. Dr. Hall will be sharing research on the linkage to unplanned pregnancy and maternal mental health. She's an associate professor in the Hilburn Department of Population and Family Health at Columbia University's Mailman School of Public Health. She is a social and reproductive epidemiologist and advanced practice nurse. Dr. Hall's research program focuses on social and structural determinants of maternal health disparities in the US and globally. Next, we have Dr. Jason Lindo. Dr. Jason Lindo is a full professor in the Department of Economics at Texas A&M University and a research associate at the National Bureau of Economic Research. Dr. Lindo's research focuses on healthcare policy, health behaviors, and health outcomes, including how they are affected by economic incentives and constraints, including the effects of family planning. Following Dr. Jason Lindo, L.R. Fox will present. L.R. Fox is the Chief Executive Officer of Next Life Sciences Incorporated, a medical device company striving to transform lives through the development of its lead program, Plan A, a contraceptive solution for men. Fox was named to Forbes' list of 30 under 30 in 2019 and has a passion for scientific innovation and solving society's most systemic problems. And next, Lisa Peterson will outline the important work she is doing in Rhode Island. Lisa Peterson is the Chief Operating Officer at VICTA, an organization providing integrated substance use, mental health, and ambulatory medical services in Providence, Rhode Island. She has a deep interest in integrating all aspects of care to support whole person wellness. Ms. Peterson is also the co-founder and co-chair of the Substance Use Policy, Education, and Recovery PAC, an organization advancing knowledge and best practices at the state level in addressing substance use and substance use disorders. Finally, Joy Burkhart will be joining us again to share the Policy Center's recommendations to improve family planning services. Welcome, panelists. I'll now turn it over to Dr. Kelly Sidham-Hall.
Good afternoon, everyone. It is such a pleasure to be here with you today. And I'm so excited to share a high-level overview of the state of the science on the relationships, the complex relationships between access to family planning, unplanned pregnancies, and maternal mental health. And I want to thank the Policy Center for the opportunity. So I just wanted to acknowledge some things that were said earlier by Ms. Burkhart in regards to priorities for maternal and mental health, and specifically research priorities in the US and worldwide. So there have been a multitude of leading public health organizations, include the U.S. Department of Health and Human Services, the National Institutes of Health, the National Academy of Medicine, and the World Health Organization, that have recently called attention to the stark disparities in maternal mental health outcomes and the contribution of comprehensive care and family planning access for preventing adverse outcomes, including death by suicide. And so part of my work has really been to advance some of these priorities in conducting collaborative research with academic institutions and community partners that is policy relevant. Next slide, please. So when I first started in conducting research in the field, there was very little scientific evidence base on the intersections between family planning and mental health. And since that time, over the last 15 years, there's been a multitude of studies, including prospective and longitudinal studies, some which myself and my team have led, that have really pointed to the role of depression, anxiety, and related mental health conditions, and their impacts on maternal mental health and the risk of unplanned and mistimed pregnancies. So we have shown that women who have adverse mental health symptoms have a risk of contraceptive non-use, of inconsistent contraceptive use of less effective methods, and contraceptive discontinuation. And in turn, they're at risk for unplanned and mistimed pregnancies. And there's also been increasing evidence to highlight the role of mental health symptoms in shaping receipt of pregnancy-related services, including during the perinatal and postpartum period, but also in the preconception and preventive years. There is a larger evidence base, in fact, that relates to the risk of sexually transmitted infections, including HIV risk and hepatitis B risk. And in part, this may be attributed to condom non-use, and as well as risk of sexual and intimate partner violence and reproductive coercion. And finally, women with adverse mental health symptoms are less likely to receive preventive care and a range of health services during the reproductive and childbearing years. And so this includes preconception and counseling and health promotion services, basic necessary life promoting services such as breast and cervical cancer screenings, and as I mentioned, STI screenings and treatment. The mechanisms linking adverse mental health symptoms to these adverse outcomes and risk for unplanned pregnancy is complex, and there's ongoing research to understand why and how these relationships matter. Next slide, please. Actually, there's been less research attention, as well as programmatic and policy attention, to the role of social stress. So stress is a ubiquitous experience, but we know that adverse life exposures, adverse life events contribute to the experiences of toxic social stress and shape women's access to quality care and their reproductive and mental health. So some of you may be familiar with the weathering hypothesis, and there's the recent work by Arlene Geronimous, as well as others that have focused on allostatic load. And what this translates to is prolonged exposure to adverse mental health symptoms and to social stress that's conditioned by our environments actually leads to biological and psychological effects that negatively impact health outcomes, both in the short and long run, and contribute to maternal health disparities in the US and elsewhere. So this is related to things like adverse exposure to racism, to poverty, to structural violence, and other social determinants of health. And there's a long-standing evidence base that shows the effects on inflammatory, immune, and neuroendocrine dysfunction. And these things can contribute to early morbidity and mortality, cardiovascular disease risk, cancer risk, and there has been a growing evidence base on the role of birth outcomes and perinatal and postpartum outcomes, including severe maternal morbidity and mortality. So this is where some of my own research is focused, and others before me, including Dr. Geronimous and Dr. Carol Hogue. We know that toxic stress disproportionately impacts the most socially vulnerable and marginalized groups of women. So racial and ethnic minoritized women, women living in poverty, and other marginalized groups. And these are the same groups, in fact, that face less access to quality care and fewer social and economic and community resources to ensure healthy pregnancies and healthy babies. And overall, this contributes to a lifelong and intergenerational risk of adverse reproductive and mental health outcomes. Next slide, please. So I just wanted to highlight findings from just one of my studies that was funded by the National Institutes of Health on the social disparities and relationships between depression, stressful life events, and unplanned pregnancies. So we studied a large cohort, a large sample of U.S. Women that were enrolled in the National Longitudinal Study of Adolescent to Adult Health. So this was nearly 9,000 women. And they were followed over time, starting during adolescence and through their adult years. And they measured a host of interrelated outcomes, biopsychosocial outcomes. And so we did some advanced statistical analysis to look at the relationships between having depression symptoms and risk of having an unplanned first pregnancy, and the implications of that in particular for racial and ethnic and low-income women. And so we found an overall effect of the risk of having depression on unplanned pregnancy. So the odds of experiencing that if a woman had moderate to severe symptoms were 1.21. So that's significant. And you can see highlighted, and sorry, the font is so small, but highlighted in the orange point estimates shown from the regression models is the significant differences across racial, ethnic, income, and age groups that we looked at. And so you can see that the risk for women who identified as Hispanic, as Black, or as Asian were significantly higher than those who identified as white. We saw the same trends for women on the lower side of the income level, and as well as women on the older side of the age groups. So these findings were published in the Journal of Adolescent Health. Next slide, please. And so we took a similar approach to look at some advanced statistical analysis and hazard modeling for the effects of having stressful life events. So what does it mean to have exposure to a whole host of stressful life events? Those are cumulative and additive and have cumulative effects. And so we saw an overall effect of the higher level of stressful life experiences reported, the more at risk a woman was for reporting an unplanned pregnancy. And so the hazard ratio there was 1.11, which is significant. And we saw higher rates of having adverse life events and unplanned pregnancies among the women who identified as Black, as compared to the women who identified as white, as well as women in the lowest income bracket. Next slide, please. And so I just wanted to comment, there's been a growing body of research, even in the past 2 years, focused on the implications of lack of access to family planning, unplanned pregnancy, and mental health for overall maternal health and well-being. So women who are at risk for lack of access to family planning, including contraception, and who experience adverse mental health symptoms are more at risk for having ongoing mental health issues with pregnancy, with childbearing, and in the postpartum period. So long-term mental health considerations for these women. There's been a couple of recent studies, and some of my own work currently is focused on what is the relationship of having those risks, including lack of access to family planning, on severe maternal morbidity and mortality. So these are the leading causes of risk that contribute to death and disability. So things like eclampsia, hemorrhage, and sepsis. And so these things contribute to the disparate risks that socially marginalized groups face in this country and elsewhere. There is some research on adverse birth outcomes, and especially preterm birth, stillbirth, and low birth weight. And there's an even larger body of research, and we're going to hear more about this in just a second, on socioeconomic outcomes. So women who face lack of access to family planning and have unplanned pregnancies have been shown to have reduced educational opportunities, employment opportunities, lifelong earnings, and social mobility opportunities. And these have long-term and intergenerational impacts, not only for the women and their offspring, but for families and communities at large, and contribute to significant costs for society and for healthcare systems. Next slide, please. And so family planning ultimately serves a fundamental role in protecting women's mental health and pregnancy-related outcomes. So there has been some research specifically looking at how we can promote reproductive agency, choice, and decision-making women of couples, and regarding whether and when and how to become pregnant and to become parents. So Drs. Ushma Apadieh and Liz Miller and others have actually validated scales to understand the contribution of reproductive agency and maternal well-being. And so having higher levels of agency and higher levels of decision-making results in planned and wanted pregnancies and healthier pregnancies, increased use of preventive services as well as pregnancy-related services, reduce stress and improve mental health, improve self-efficacy, self-confidence, and life satisfaction, including in the short term. And the landmark study by Dr. Diana Green Foster and others at UCSF have shown this. Improved socioeconomic outcomes for both women and families, and that's also been shown by the Turnaway study. Improved early child development outcomes, as well as equity, so equity across groups in public health priority indicators. Next slide, please. And so I just wanted to conclude by saying reproductive health care settings are actually an optimal opportunity to promote women's mental health during the childbearing years, and often an untapped resource. Family planning and gynecological and obstetric settings are critical points of access, and often for many marginalized groups of women, the sole sources of healthcare during the preconception years, the perinatal and postpartum years, even the parenting years, and throughout menopause. So this is a point of opportunity, a window of opportunity, if you will, if we take a life course perspective. And some of my own research, as well as that of others, have shown that women actually express some preferences for integrated models of care. So the idea that we can integrate mental health and behavioral health services into family planning settings. We heard a little bit earlier around the role of federally qualified health centers and Title X clinics in promoting access in these ways. Increasing access to stress and social services so we can address those fundamental social determinants of health, including violence and trauma. Women express preferences, and more is coming out in this in regards to maternal health for culturally congruent and patient-centered care and unbiased care, especially in helping reduce disparities and promote equity, and community-driven solutions to integrated care models. So I'm happy to talk more about those opportunities in the Q&A, but just a comment to say and set the stage for the final presentation today that there are evidence-based policy solutions that can assure women's access to quality and comprehensive care. Thank you. Now I'm going to turn it over to Dr. Lindo to talk more about the economic implications.
Great. Thank you so much. I thought I'd start this talk by differentiating between economic theory and economic empirical research, because I imagine folks might be familiar with economic theory, but less familiar with empirical research in economics. And so, of course, if you've taken introductory economics class, you might know that economic theory typically involves us thinking about individual behaviors being influenced by incentives, costs, and constraints, which then affect their outcomes. What you may not be familiar with is that there's a lot of empirical research in economics And researchers like myself who do that type of research, we are obsessed with estimating causal effects. And so, for example, where we see a correlation or an association between two things, we are obsessed with trying to understand whether that relationship might be spurious versus whether it might be causal. Next slide, please. And so the methods that we use to try to estimate causal effects are typically associated with the 2021 Nobel Prize in Economics and cutting edge refinements to those methods, which typically involves evaluating natural experiments, or what we call natural experiments, which are circumstances in which institutions, policymakers, or perhaps other forces have generated an experiment of sorts that we can learn from. Okay? And so when we approach these experiments, we're focusing on trying to identify a counterfactual for what happened. That is, what would have happened if circumstances had been different. So next, I'll go through an example to show you what I mean. Next slide, please. And so this example is from my own research, where I was evaluating the effect of the Colorado Family Planning Initiative, which was a $23 million program aimed at expanding access to long-acting reversible contraceptives through Title X clinics beginning in 2009. Next slide, please. Okay, so this figure here shows the evolution of teen birth rates in Colorado counties with Title X clinics. So very clearly here, you see that the teen birth rate fell dramatically after the Colorado Family Planning Initiative was implemented. The question, however, is how much of that decline is due to the initiative versus how much might have happened anyways. And so to answer that question, we need some comparison group to help us learn about that counterfactual. So what we did is we looked at what happened to the evolution of teen birth rates in other US counties with Title X clinics. Next slide, please. And so what you can see here in the dashed line is that the teen birth rate in these other US counties, it fell too. So part of the reason that the teen birth rate fell in Colorado was because of these nationwide forces. But the teen birth rate fell much more rapidly in Colorado than it did in these other US counties, which is indicative of the Family Planning Initiative having a causal effect. And we measured that effect to be 6.4%. Next slide, please. Okay, so I do want to highlight there are a huge number of studies of impacts of policies on childbearing. And policies altering access to family planning affect the timing of childbearing and completed fertility. In the interest of time, I'm not going to talk about that research. I'm just going to focus on estimates of causal effects of family planning, fertility timing, and family size on other outcomes. Focusing on what I think of as some of the most definitive research. Also with a slant towards economics research, although of course I appreciate that a lot of great research has been done by folks in other disciplines. Next slide, please. So in terms of the effects on education, we know that early legal access to contraception is associated with, and actually I would go the next step and say causes increases in education, especially for women from disadvantaged background. We saw in the 60s and 70s increases in access in women's teenage years, increased educational attainment by about a half of a year on average for women from the bottom third of socioeconomic status index that Bailey and co-authors created. And all this access to contraception also increased enrollment in professional schools. Next slide, please. In terms of the timing of childbearing, that can also be critical, especially when you think about young individuals or even older individuals who are still making important investments in their education and more broadly in their careers. And so there's research showing that avoiding childbearing before age 18 increases GED completion by 5 percentage points, and it increases education levels by 0.15 years on average. In terms of the timing of a birth being just before versus graduation or expected graduation versus just a few months later, well, that can also have substantial causal effects on high school graduation. And indeed, there's research showing that it is substantial, and that there are long-term consequences on subsequent outcomes besides education, which I'll get to in just a moment. Next slide, please. So in terms of labor force participation, research shows that legal access to contraception increased women's labor force participation by 8%. And this is thinking about access to contraception when women were in their adolescent years and all late teens. And this is affecting their labor force participation when they are in their late 20s. Okay, and other research has shown that the effects seem to persist well beyond those ages. There's also evidence showing that avoiding childbearing before age 18 increases subsequent labor force participation by 5 percentage points. Unplanned births reduce labor force participation by 4 percentage points. Next slide, please. Okay, there are also effects on income and wages, which of course is the other margin of income. You know, whether or not someone is working, and if they are working, how much are they making? Those are the two components of family income, of course. And we know that there are substantial effects on hourly wages when we think about early access to contraception. These effects persist into women's late 40s. Okay, so access to contraception when women are young affects their lives for decades. Okay, that appears to be in part due to impacts on their ability to participate in the labor market, and also in part based on effects on their education and the occupations that they ultimately go into. It's also the case that there are effects on the likelihood that women are near or below the poverty line. And we also see impacts on poverty rates and welfare dependency when we think about avoiding childbearing before age 18 and unplanned births more generally. Next slide, please. It is really important, I think, to consider that the effects, these effects that I've been talking about, will be felt beyond the women themselves, but by their families, including children that they may already have and children that they may have in the future. And so research that looked at the initial rollout of the federally funded family planning programs, for example, from the 1960s and 70s, show that reduced the share of children living in poverty by 7%. Okay, and so we should also think that policies affecting family planning today will also have similar effects on the share of children living in poverty, given that it affects labor force participation and it affects wages. And it also puts strain on households in terms of the expenses that are required for having and raising children. In terms of effects on children, it's also the case that unplanned births increase the likelihood of divorce, and they have negative impacts on the IQ of previously born children. And so those impacts, I think that sort of speaks to the intergenerational effects that were mentioned previously. Next slide, please. There's also a lot of research on abortion access. I have some text here and some citations, but in the interest of time, I'm just going to say that there are the same general conclusions in that the research in this area indicates that people's ability to control how many children they have and when they have them has significant effects on educational attainment and downstream outcomes such as financial distress. Next slide, please. So in terms of the bottom line here, I would just emphasize that there is a wealth of research showing that pregnancy and childbearing have significant effects on educational and economic outcomes for women and their families, including their children. And there's strong evidence that these outcomes are affected by policies altering women's ability to control childbearing. I would also highlight that there are some research areas where, you know, some of the evidence points in one direction, some of the other evidence points in the other direction. This is not one of those areas. This is an area where pretty much all of the research is pointing in the same direction towards these conclusions. And I will leave it at that and turn it over to the next speaker.
We are.
Hello.
There we go.
There we go. And if someone can allow me to turn on the video, we should be good to go. There we go. Good to see everybody. It's really great to be able to be here and present today. And my name is L.R. Fox. I'm the CEO of Next Life Sciences. Now, when we talk about maternal health, let's be very clear what we're talking about. We're talking about the health and success of mothers, of women, their children, and their families, and the communities and economies that surround them. And what is one of the key ways we can set women up for success? As my fellow presenters have shared, we can and must empower women with more options and channels that allow them to better choose when and if to have a child. Statistics currently recognize that half of all pregnancies are unplanned worldwide. And the unintended pregnancy rate is significantly higher here in the United States than in any other developed country. Now, you heard that right. We currently have half, a coin flip odd, of being able to make one of the most significant, impactful decisions of your life. And why is it half? I believe it's because for far too long, Big Pharma has completely ignored half of the entire population, men, placing the majority and oftentimes total burden of family planning solely on women. As I'll reference in a bit, the stats are clear. We haven't focused enough on male contraceptive options, and men are eagerly awaiting the opportunity to participate in family planning. But let's zoom out a bit. It's an undisputed fact that the holy grail of contraception is known as LARCs, as we've talked about today. People want something that is LA, long-acting, AKA set it and forget it, until you're ready to have kids. And that's the key, until you're ready. And when you are ready, that's where the big R comes in, reversible contraception, LARC, LARC. Now let's take that one step further, because the holiest of holy grails is known as non-hormonal LARCs. That is all of those benefits without any of the potential side effects inherent to hormonal methods. So call me Indiana Jones. Let's look for some holy grail. Since founding Next Life Sciences, I have been dedicating my life to developing the first non-hormonal LARC for men, which we're calling Plan A. And I have it right here with me. Now, I believe that LARCs, like Plan A, are a key contribution to what enables better gender equity, maternal health, family well-being, and individual autonomy. Giving people access to a wide range of family planning options empowers people to realize the agency they have in choosing when and if to have a child, thus enabling three key maternal health and socioeconomic indicators. One, the woman's age during her first pregnancy. 2, the determining of the time between pregnancies. And 3, choosing the desired total number of children. Contraception empowers individuals to have more control over their lives and futures. Today, I'd like to reiterate an important and big idea, maybe the only idea with the potential of doubling access to contraception. And we're charting this new path. This is how I propose that we make sure to include contraception options available to men. Because let's be honest, men are often left out on the outskirts of family planning. And for far too long, the burden of contraception in reality and in rhetoric has largely fallen on women. I believe it doesn't have to be that way anymore. Contraception for men is an area of innovation that researchers around the world have been working on for decades. But today, contraception for men generally only means discussions about condoms and vasectomies. So either a temporary solution with a high failure rate or a permanent sterilization that involves snippage. Methods that leave a massive gap for the millions of men who are looking for long-term and reversible solutions. Today, I'd like to share with you some of the exciting and important changes I've seen taking place in the area of male contraception. First, there's an area of this is an absolute area of rapid innovation and growth, something that I'm fortunate enough to help lead. There's current research underway on sperm suppressing pills, topical gels, and other forms of contraception for men. As mentioned earlier, I'm a part of a team of passionate doctors, scientists, and medical engineers bringing to market the first non-hormonal LARC for men, Plan A. Now, Plan A uses a design that involves a biocompatible hydrogel, right here. This technology is simply injected into the vas deferens, right here. For those of you who didn't study for the biology pop quiz today, this is the tube that the sperm travels through and what's snipped during a traditional vasectomy. Now, as we look at the research here, we see that the entire system can be designed to be non-hormonal and be both long-acting and reversible at the same time. And this can be done through a simple doctor's visit that allows you to dissolve the hydrogel. Now imagine how revolutionary it'd be to have a 10-minute doctor's appointment that can result in 10 years of safe protection and family planning for men. And that's our vision for Plan A. Now, some of you might now be asking, that's great, but even with this new technology, are men going to participate? Well, an equally important change we're seeing take place recently is that men are taking an increased interest in and engaging more with their reproductive health, especially since the Dobbs Supreme Court decision. Since this decision, we have started to see that both men and women start to take more action to prevent pregnancy, either out of panic, confusion, or a greater sense of equity, shared responsibility. Now, urologists have shared their experiences and seen an increase in vasectomy procedures in their practices throughout the past year. At a urology conference, one leading doctor shared vasectomies have increased significantly across the country since overturning Roe v. Wade. This represents an unprecedented shift in reproductive health behavior by men. The Economist recently reported insurance data showing that vasectomies shot up 29% in the 3 months after Dobbs, and that men getting vasectomies are skewing even younger. Other studies have shown the trend to be clear. More men, younger men, and even men without any children are getting vasectomies since the Dobbs decision. Finally, data released just last month showed that men's willingness to use new forms of male contraception, even within the very first year of release, was increased by 26% after Dobbs. Now, clearly, men's behavior, awareness, and interest in contraception is growing. Now, these are the following steps that I challenge us to take to make male contraceptive options more accessible. We need to normalize the conversation around family planning methods. These conversations must include forms of male contraception. 2, we should talk openly with our families, with our healthcare professionals, and among key policy and opinion leaders, such as those here today, about the entire breadth of options available for family planning. Number 3, we should recognize the trend of male interest in vasectomies as a clear demonstration to their willingness to participate in family planning. 4, it is vital that we ensure accessibility including mandated private and public health insurance coverage for male contraceptive options, to remove any financial barrier that currently prevents males from accessing those effective options, including vasectomies, but also new contraceptive methods. And finally, number 5, we must allocate federal funding towards new and novel forms of male contraception. For every dollar spent on female contraceptive research, less than one penny is spent on male options. As we discussed, LARCs for men have the potential to revolutionize the health and well-being for millions. The sooner we invest, the sooner we promise we can meet that promise to provide better and accessible contraception for all. This is the future. In conclusion, as the landscape of reproductive healthcare is changing all around us, we must conceive of bigger, more expansive possibilities for family planning. And that means thinking beyond the bounds of contraception for women only. We have an opportunity to relieve the burden on women and to contribute to maternal, mental, physical, and economic health by giving more people access to the types of contraception that works best for them. Because when we increase people's ability to decide when and if to have a child, that's how we help women, men, families, and communities thrive. Thank you so much for having me, and I'm going to pass it over to the next speaker.
Thank you so much, Fox. That's super exciting to hear about the advancements. My name is Lisa Peterson. I'm the Chief Operating Officer at VICTA. We're an organization in Providence, Rhode Island that offers fully integrated behavioral health and medical care. We've been in operation for about 4 years, and VICTA was first started because the founder CEO saw that the silos in healthcare were causing harm to the people that we served in the behavioral health realm. This has been something that I've come up against in my career over the past 25 years, and it's something that I've worked really hard to try to find solutions for. So we have our medical system where traditional conversations about contraceptive care and pregnancy and childbirth are held, but we've got a lot of folks who are in mental health treatment who have medical needs. We've got folks who are in mental health treatment who have substance use needs, and these systems don't historically interface very consistently or very well. And these silos ultimately lead to repetition for folks. They lead to barriers to getting to additional care, barriers in care coordination. So when VICTA was conceptualized, and you can move to the next slide, it was really designed to integrate all aspects of the person being served in one spot. So the initial vision was that we would be an opioid treatment program or a methadone clinic with ancillary services so that folks who are on medications for their opioid use disorder could access necessary care with low barrier availability and in an environment where they don't face fear, bias, and discrimination. That is often a driver of folks who have substance use disorder or folks who are using alcohol and other drugs getting into care, is that they are fearful or have had negative experiences based on the symptoms that they present, or the medical symptoms that they present with are written off as related to their alcohol or other drug use when that is not always the case. So it really creates poor outcomes, and it makes our folks a little bit shy to get back out there. Since our inception 4 years ago, we've served over 4,000 people, and methadone is actually our smallest program. The need for general outpatient services, alcohol remains an enormous crisis across the country, and the stimulant surge is definitely coming to the Northeast. So we're able to offer intensive outpatient programs, services that offer 3 hours, 3 days a week of intensive group counseling, as well as individual counseling, family counseling when indicated, all again in our one flagship office here in Providence. We have mental health counselors. We have counselors who are duly licensed to provide both mental health and substance use services. That's something that I pursued in my career very early on because it made no sense to me that there were certain aspects of a person's functioning that were off limits for a therapist in a given setting. So we really are developing a staff who is really savvy about integrating comorbid issues, and expanding that into the medication realm. So we have a psychiatric nurse practitioner here. We have multiple prescribers who offer medications for opioid use disorder and alcohol use disorder. And again, because of the fear, bias, and discrimination that people with alcohol and drug use face and people with mental illness often face, we were licensed by the Rhode Island Department of Health to do ambulatory medical care. So urgent care type services. For example, somebody comes in to take their medication and the nurse notices that they've got a burn on their forearm. They work in a kitchen, they've burned themselves. They probably were not going to do anything about that and run the risk of an infection or something worse developing. So we were able to turn them right around, put them in with one of our prescribers, get that taken care of before they left. In my experience, when you give someone a referral or a card or an appointment that is outside the walls that you're starting from, the chance of them following through on that is pretty low. So we're able to do all of that in one stop, which has been phenomenal and has literally helped us save lives in other ways beyond overdose prevention. You can go to the next slide. So in early 2021, I was contacted by the Rhode Island Department of Health and asked if we would be interested in partnering with an organization called Upstream. The Department of Health had VICTA on their radar because we had developed a little bit of a niche working with pregnant and postpartum folks who were on medications for opioid use disorder and doing a lot of community training around what to expect, neonatal withdrawal syndrome, how to take care of an infant who may be experiencing withdrawal, how to support the pregnant person throughout their recovery path and keeping them stable and having a healthy full-term delivery. So we were already sort of exploring that opportunity with our ambulatory medical services. And when Upstream contacted us, it sounded like an absolutely perfect complement to what we were doing. So Upstream provided us with extensive training for our counselors, for our front desk and administrative team, and for our prescribers to start to have the conversation about whether individuals want to become pregnant, are planning to become pregnant, are taking any action to prevent becoming pregnant if they don't want to become pregnant, and to start to normalize those conversations as part of the whole person approach to their care. So we went through extensive training. We adapted our electronic health record to support routine screening for pregnancy intention, routine tracking of types of contraceptive methods, and routine access to immediate contraceptive care if someone indicated a need. So we now have a fully stocked semi-pharmacy with long-acting reproductive options as well as other shorter-acting options. We have the full scope of contraceptive care here, and we're able to offer that to folks right in that moment when they're feeling motivated to do it, and they feel really, really safe here. We also had support from the Upstream team, fortunately, to look at coding and billing. One of the biggest challenges, and this harkens back to the silos in our healthcare system, is that there are silos in our payment models as well. So we are providing fully integrated care, not co-located care, not we have a doctor for your medical needs over here and a different doctor over here for your opioid use disorder needs. The same prescriber is going to speak to you about your methadone or buprenorphine and your interest in getting an IUD. So the challenge that creates is that many of the payers are divided by quote unquote behavioral versus quote unquote medical services. So it was a lift to understand how to effectively bill for both when they were occurring concurrently. And Upstream was able to provide a great deal of technical support around that. We also partnered with other organizations who had been working with Upstream, and in fact, due to their other partnerships in Rhode Island, one of my nurse practitioners was able to do live precepting for IUD placements and removals right here in our local community, and to create that kind of back and forth partnership and referral opportunity for the other health centers. So we've been really fortunate to have worked with them over the past 2 years, and I can share a little bit of what it looked like when we were able to implement this in the next slide. So this is a screenshot from our annual and initial biopsychosocial. So as part of routine questions about medical history, family history, substance use history, mental health, we just ask people if they would like to become pregnant in the next year. And if they say no, we ask a little bit further. would you like to receive contraceptive education? Would you like to talk about your options? Do you already have a plan to avoid an unintended pregnancy at this time? And so the counselors start that conversation. If they indicate interest, we have an internal referral process right to one of our prescribers who's able to talk through all the options and help the client and themselves come to a decision about what makes the most sense for them. Next slide. In the prescriber's evaluation and management note, we added a simple checkbox of whether or not they spoke to the individual about contraceptive education. And then we added a drop-down list that'll allow us to track trends in terms of what people are already using or would like to be using after their interaction with our prescriber. So on the next slide, it shows a little bit of the outcomes of this data collection, thanks to our EHR. There were definitely some challenges, some logistical challenges in getting the data collected in the most effective way. But by the end of last year, we had a really solid process for pulling the reporting that we would need. So we look routinely at each month or each quarter, how many people had an initial or annual biopsychosocial assessment with their counselor. And of those who were assigned female at birth or had the potential to become pregnant, we queried whether or not they had been asked the question about whether they intended to become pregnant or wanted to become pregnant in the coming year. So what we've identified is the overwhelming majority of our folks do not want to become pregnant in the coming year. The challenge with our population is that when they are actively in their substance use disorder or in mental health crisis, it's really difficult for them to make safe choices for themselves and to take good care of themselves. So they may be having unprotected sex, folks may be engaging in sex work, or they just may simply not understand that they have these options, what the variety of options are, and how they can access them. So again, most of our folks not interested, very few are okay either way, and the ones who are not, we really explore, would you like to talk further about that? You can go to the next one. The outcomes that we see with our evaluation and management visits help us get a little bit of an understanding of what folks are currently doing to prevent pregnancy. And as we accumulate more and more data, that will help inform our stalking, our scheduling, et cetera, so that we can make sure that, again, when somebody is looking for that contraceptive choice, we can provide it essentially same day and have them set up with the prescriber, have them walk out the door with a method in hand. You can go to the next one. So the other outcomes were that our nurse practitioner has been fully trained in all of the contraceptive methods as a result of the partnership with one of our local community health centers. We have set up the account that we need with our medical supply services. We have transformed one of our offices into a gynecology-friendly office. And in fact, I'm really excited to share that we hired a gynecologist in May. And as of this month, we are offering a full range of reproductive health care, from screenings and PAPs and breast exams through contraceptive counseling and services. We were able to get the appropriate CPT codes and ICD-9 diagnostic codes so that our billing can continue without a hitch as we expand this service. And we will be offering routine STI testing to any of our clients, wellness screenings, et cetera. The most important and exciting thing for me in this work is that a lot of our folks have experienced sexual trauma. That is overwhelmingly large numbers in the population who use alcohol and other drugs. And that is another factor that's a barrier to them accessing routine wellness care. Many of our clients have not seen a primary care doc, a gynecologist, a specialist for many, many years, and it puts them at risk of greater health concerns. And we don't want to see people get into long-term recovery and do all this work on themselves and then suffer from something that was neglected over the time. So we are able to provide trauma counseling that can help somebody prepare for something like a pap smear. We can do exposure. We can have them sit in the room, meet with the physician long before they even schedule their actual procedure, which is something that a lot of clinics just don't have the capacity to do. So we are thrilled to be able to add that to our services and truly can now say that we take care of the whole person once you get through our doors here at VICTA. So I'm really excited, and thank you for letting me share about our team's work and our partnership with Upstream. It's been a phenomenal effort, and I hope it can be replicated.
Thank you so much, Lisa. And it's incredible to hear about the innovation that you're leading in Rhode Island, and that we can see integration happen in the reverse, as you pointed out. Thank you so much. And I'm pleased now to share some of the recommendations coming out of the Policy Center for Maternal Mental Health. For members of Congress in particular, these are federal policy opportunities. You've heard today that there's an ample opportunity to take a closer look at ways that we can expand free and easy access to contraceptive methods of choice. Doing this through traditional platforms as well as non-traditional platforms, FQHCs and CHCs, community health clinics. Further investing in Title X, the Federal Family Planning Program, is critical. We can also think about novel ways to engage the Women, Infants, and Children's Program, WIC, through potentially solving for access issues related to contraception. You heard earlier some of the speakers talking about the importance of the FDA making contraception available over the counter. Those decisions are being made, as we understand, as we speak, and also making sure that those over-the-counter options are available at no cost. The protections that are in place through the Affordable Care Act for preventive care, for contraception coverage, and then require all FDA-approved contraception without insurer or health plan limits or other requirements. Next slide. Number 2 is to think about the role that OBGYNs, midwives, and doulas can play, an expanded role perhaps in providing robust family planning counseling services. There seems to be an opportunity to define these roles for these providers in a more comprehensive way, and utilizing the person-centered contraception counseling, PCC, framework that's addressed in the issue brief and is being raised by many leaders in the field addressing contraception. We also would encourage federal government and agencies to think about reimbursement for these types of providers and billing pathways through Medicaid and private insurance, commercial and ERISA plans. Do providers understand how to bill, for example? That's where the rubber meets the road. And if they don't, often we see gaps in delivery of these kinds of services. And number 3, promote and incentivize forthcoming male contraception options. You've heard about one of them that's in the FDA pipeline already. And so we want to see that men understand that these options are available and what role can the federal government play. And these likely new FDA-approved methods, and consider incentives for distribution, marketing, and uptake. Next slide. And then empower the Department of Labor to oversee contraception coverage, or similar to the federal mental health parity law. We have seen that the Department of Labor has been able to expand jurisdiction to address enforcement and oversight of delivery of that benefit. And so to identify a federal agency such as the Department of Labor to oversee all access to contraception and where there might be gaps with insurance coverage or denials, for example, of coverage at no cost. An agency like the DOL would be a helpful agency to oversee and enforce gaps in delivery of that benefit. And one last recommendation, we'd be remiss, of course, if we didn't talk about the social and infrastructure supports that are needed for families that do end up having babies here in America. And if we have to start by providing these benefits to any populations, of course, we should be prioritizing low-income populations and single-parent families. Child tax credits, I know many of you know the importance of those credits to support families in raising children, paid parental leave, and free childcare to allow parents who want to work be empowered to work and have free childcare in those cases. And we're excited about the 2 bipartisan congressional caucuses that are working on those 2 issues: free diapers and formula for those who are unable to breastfeed or choose not to breastfeed, critically important. And then coverage for postpartum in-home support for things like having time to heal and rest after birth, attend appointments, and have support caring for sick infants and children at home. And with that, I'd like to again thank you on behalf of the Policy Center, and now turn it back over to our moderator, Dr. Fredrickson, to support the Q&A session of today's webinar.
Thank you, Joy. And thank you to all our presenters. Those were fabulous presentations. We've had a number of questions in the Q&A that have been answered, but we have a few that we'd love to answer live. So this question is for Dr. Lindo and Dr. Stidham Hall. What is the methodology used in the studies that you presented on? Are they advanced methods, and who are the comparison groups? And the question also said, is it their sisters or young women who miscarried or had abortion? So more on the comparison groups.
I talked about a handful of studies using a variety of methods, all sort of falling under the umbrella of evaluating things we might consider natural experiments. Many of them involve analyses of policy evaluations, and so those would typically involve comparing how outcomes change either over time or across successive cohorts in places that changed a policy relative to how outcomes change in places where policy didn't change. And so the policy could be affecting legal access to family planning or affecting financial support for family planning. The other sort of type of study that I referred to in my set of slides was studies evaluating quasi-random shocks to pregnancy. And some of those would include studies looking at miscarriages, which are largely random and delay childbearing, and for some women reduce completed childbearing. And also studies where slight differences in timing of pregnancy could possibly affect outcomes, and analyses of the effects of those slight differences in the timing of pregnancy.
And I'll just quickly add, my charge was really to provide a high-level overview of the state of the science, and I covered a huge range of various public health indicators and outcomes, and where possible, really trying to comment on the most rigorous and quality designs and level of quality of evidence, including the studies that were prospective, where data collection was prospective and longitudinal, as Jason mentioned, the quasi-experiments. And so the strongest body of evidence is really where there's a really rigorous control group and an appropriately selected control group. So for instance, I mentioned the Turnaway study was one example. And overall, for the most part, I commented on the sort of summary of trends and findings in terms of the positive influence of access to family planning on improving outcomes. But there are some inconsistencies in some of the findings, in some of the outcomes, based upon different measurements that were used in terms of different survey instruments, different populations, and different subsamples. And so there are some differences across some of them. But I think that collectively we've tried to really comment on the strongest body of evidence out there today.
Thank you both. We have a question for Lisa. Have you encountered pregnant and postpartum people receiving medication support to treat their SUD, having difficulty with child protective services or law enforcement because they were reported for child abuse simply because of their medications?
That's a great and very timely question. We are very fortunate here in Rhode Island, and VICTA in particular, with our partnerships. Rhode Island does not include medications for OUD as part of a reportable test at birth. So unfortunately, that's not the case of a lot of states, including our neighbor Massachusetts, where that in and of itself requires a mandated report. We also have a lot of protective factors in place for our pregnant and postpartum folks. So we have doulas are a covered benefit here in our Rhode Island managed care plans. We have peer recovery specialists, which are a covered benefit. And we've got great relationships with our primary birthing hospital, Women and Infants, where they are really trained to help the delivering individual and the infant still have that bonding time, even if the infant needs to be in extended care for their neonatal withdrawal syndrome. So they essentially check the delivering parent out of the hospital, but allow them to stay almost in a hotel manner so that they can have skin to skin and breastfeed, etc. So we're really lucky to be sort of ahead of the game here with that in Rhode Island. And at this time, the only reportable tests would be for quote unquote illicit substances. And in that case, we also work really hard to advocate for the person to get treatment and to try to stay together with the family, which is generally best for the infant.
Awesome. Thanks, Lisa. There is a question for anyone presenting on research, how LGBT populations fit into the research you presented. Anyone speak to that?
I can start by just commenting that this has been a completely underrepresented group in the context of maternal health research nationally and internationally. And so there's been significant attention to investing resources to get better design studies and better inclusive studies to engage this group. And so for the most part, when we were referring today to the literature that's out there, it really was for people who self-identify as women in the sheer limited ways in which researchers have historically measured that indicator of gender. And so I think there's been a huge push from the NIH as well as the National Academy of Medicine and others in terms of best practices for standardizing and improving our approach to measure gender in these studies and be more inclusive. So I think that's a work in progress, but a really important question.
I agree. Thanks, Kelly. And then a question for Fox. What can Congress do to most immediately help with getting contraception more available for men?
Yeah, it's a great question, especially when we have eager congressional representatives that are seeking to be able to participate. The two biggest things that Congress can do is one is ensuring that all private and public health insurance plans cover male options, both ones that exist today, which is such as vasectomies, as well as new methods that are approved by the FDA. That currently is not the case. Not all plans have to cover male methods, which really just emphasizes that the burden's on women. And then finally, NIH is spending millions of dollars on contraception, but over 99% of that is for female methods. And so, as we talked about, there's the other half of the population that's eagerly waiting male options. Funding from the NIH helps to speed along research, as well as to ensure that research is properly focused on groups of the population who are otherwise underrepresented.
Yes, thank you. And unfortunately, I think we're out of time, but I want to thank all of today's speakers. And on behalf of the Policy Center for Maternal Mental Health, we thank you all for attending and for your ongoing commitment to maternal mental health. Have a wonderful day.
Thank you.